Hi guys, so this is the third in the series of surgical presentations, and today it's going to be focused on diverticular disease. As always, you can get in touch with myself on davidormonks@gmail.com, or if you're interested in emergency medicine, you can give me that on Twitter, and I post up various little tidbits on that. So, as you mentioned in the first topic, you guys are fairly limited for time, so what we've done is had a look at the various surgical presentations and tried to choose from that the list of kind of high yield topics and surgical conditions that can occur and that may well be on your long case. So today we'll focus on diverticular disease, which is one of the topics on the list. And there's a bit of nomenclature to know around this. So diverticular disease equals diverticulosis. There's no difference between the two, and the two terms can be used interchangeably. So a diverticula is an outpocketing of a colonic mucosa and submucosa through weaknesses of muscle layers in the colon wall. More commonly, this occurs in the sigmoid colon, and that's because there's higher pressures involved there. You've got reabsorption of water up until that point, and the stool is becoming more formed, and this lends itself then to higher pressures. So this is more common in patients who suffer from constipation, and it's quite uncommon before the age of 40. However, as a colorectal intern, I have had patients in their 30s presenting with simple acute diverticulitis, so it definitely should still be on the differential in young patients with left lower quadrant pain. So diverticulitis then, moving on from diverticular disease, how does this present? I suppose if you can just appreciate that you've got kind of liquid stool coming up your ascending colon, coming across your transverse colon, more water is getting resorbed, and eventually in the sigmoid colon, descending then into the sigmoid colon, you've got higher pressures, and these higher pressures lend themselves to the formation of diverticula. Within these diverticula, then stool gets trapped, forming fecal lift. Anytime you've got stasis of material that contains bacteria, it lends itself to inflammation, and this inflammation then causes diverticulitis to develop. So how may someone present with diverticular disease or with diverticulitis? So diverticulosis can often be asymptomatic, can be an incidental finding if the patient's gone for a CT for a different reason. So some literature will say that the patient may have some slightly irregular bowel habit or have increased flatulence. But one of the main things you need to be cognizant of in terms of diverticulosis is the potential for bleeding pure. And this can often be severe, giving rise to hematochezia, or bright red blood pouring from the back passage. So this occurs in diverticulosis as opposed to diverticulitis, because it's thought that the inflammation in diverticulitis actually helps to seal off the blood vessels, and therefore it's less likely to occur in diverticulitis. Diverticulitis generally presents as left lower quadrant pain, fever, tenderness, and the patient can be quite unwell, can actually be septic with this. So any surgical condition, when you're taking a history, you're trying to ascertain the risk factors and what risk factors the patient may have for this condition. So there's not too many in terms of diverticular disease. 40% of it is thought to be genetic component and 60% environmental component. Constipation is the biggest risk factor, and that makes sense when you think of the pathophysiology of how the diverticula and diverticulitis develops. And obesity, as well as increasing age, then are the other risk factors. So in terms of complications then, this is a list of them that can occur, but you can group them. So anytime you're thinking of diverticular disease, diverticulitis, you're worried about perforation. When you get perforation, you can get abscess formation, or if it goes beyond that, and you get the leaking of purulent or fecal material into the abdomen, this can give rise to then peritonitis. So these three should be remembered in tandem. Other than complications that can occur are strictures, which can lead to then bowel obstructions, and you can also get fistula formation, whereby a diverticula erodes into either the bladder, giving rise to colon-vesical fistula, or erodes into the vagina, giving rise to colon-vaginal fistula. You can also get intracutaneous fistulas, but these are less common. So Hinch et al. Back in 1978 came up with a classification system for diverticular disease and when a colonic perforation occurs. So the grade 1 gives rise to a localized abscess, so paracolonic, just beside the colon. Hinchy 2, whereby you've got pelvic abscess, so a large abscess within the pelvis. And then Hinchy 3 and 4 is whereby the patient has peritonitis, and Hinchy 3 is purulent peritonitis, so that's pus within the abdomen, and 4 then is fecal peritonitis. This is a graphic representation of the classification system, and we can see in 1 and 2 where you've got abscess formation. This actually may be amenable to interventional radiology drainage, and the patient may not require surgery. 3 and 4, however, generally would require surgery, and the patient may have to actually undergo surgical resection with stoma formation, or more commonly a Hartmann's procedure. In terms of the history, you want to ascertain, does this patient suffer from constipation? Have they had previous episodes of diverticulitis? Have they a known diagnosis of diverticular disease? And then you're cognizant of then complications. So in terms of a colovesical fistula, does the patient get frequent UTIs? Have they noticed that they're passing air when they urinate? In terms of female patients then, have they got any discharge from their vagina? In terms of any risk of bleeding, I just asking the patient, have they noted any blood PR? Anytime a patient has diverticular disease where they may have a change in bowel habit, you always need to be cognizant of malignancy, so it's prudent to ask about weight loss. And you also then would be thinking about inflammatory bowel disease if the patient is developing things like enterocutaneous fistulas. Inflammatory bowel disease has a bimodal distribution whereby it can occur and often presents in the 20s and 30s. However, it can also present when a patient's in their 50s, 60s, and even 70s. In terms of the exam, you, as with any surgical patient, want to ascertain if the patient is anemic or not. So you're looking at the hands, pallor of the palmar creases, at the conjunctiva. At the abdomen, you want to determine where the abdomen is tender, and you want to outrule rebound tenderness, which again is a sign of peritonitis. You want to ascertain whether or not Bell's are present or absent, if there's any evidence of any enterocutaneous fistulas, previous surgeries, or if there's any evidence of any hernias, which may be giving rise to the patient's presentation if he does indeed have a strangulated or incarcerated hernia giving rise to the patient's acute abdomen presentation. So what investigations are you going to do? As always, you should break down your investigations into hematological, radiological. So in terms of hematological investigations, you always want to do a full blood count. In a full blood count, you're looking for iron level. You also want to assess white cells, and you want to look if neutrophils are raised as well. So this is neutrophilic leukocytosis, which is raised white cells with predominantly neutrophil component. And this corresponds to bacterial infection. If it's raised white cells with a largely lymphocyte component, that corresponds to viral. So we would be expecting a neutrophilic leukocytosis in diverticulitis. You would want to assess UNE, or urea and electrolytes, for a patient. You would want to get a baseline renal function in order to help dosing of medications such as your antibiotics. You would also like to assess if the presence of acute kidney injury, which would then mean that this patient may have septic shock, as it would be a sign that there is decreased end-organ perfusion. Other hematological investigations you would do would be a venous blood gas to assess a lactate, which again, another marker of end-organ perfusion. Any patient that you're worried about in terms of having infection or being septic, you would do blood cultures on, and I suppose with one of the complications of this being bleeding or the potential for the patient requiring surgery, it's always prudent to take a group and hold, as in taking a patient's blood sample so that it's sent to the lab and they can cross-match his blood type, such that if you need to give the patient blood, the lab can do that and there's no delay. And then in order to monitor how the patient is going in terms of their infection, you should get a CRP, which is a good marker of inflammation. With the CRP, it can rise within 12 hours. It generally takes kind of maximum of 48 hours to peak. So a patient may present, you may put them on all the correct treatment. They may be clinically improving. However, their CRP day 2 may rise, and that's because there's generally a lag until it rises. And after 48 hours, then it should generally come down if the patient is clinically improving and on the right treatment. Radiological investigations then you would do an erect chest x-ray. So erect is important in order to facilitate any potential potential air within the abdomen rising to under the diaphragm, which is what we're looking for when we get an erect chest x-ray. So the patient needs to be sitting for a minimum of 5 minutes bolt upright before getting this. So it's just to repeat what we've been saying. You then would, obviously after the chest x-ray, want to get a CT abdomen for the patient. If, however, there was evidence of peritonitis, the patient was very unwell, it may be the case for going straight to theatre and skipping this investigation. So here we have a chest x-ray. Just to go through the spiel that you should go through anytime you're looking at a chest x-ray. You would comment on the name of the patient and whether or not the chest x-ray was taken in AP or PA. Here we can see it's AP, meaning that it's portable, so we can't comment on the heart size. So you would say something like, here we have a chest x-ray of Mr. Bloggs, and the most obvious abnormality is air under the right hemidiaphragm, which would be concerning for pneumoperitoneum. You would then go on to look at the rest of the chest x-ray and comment on the airway, that it wasn't deviated, that there was no evidence of bony injury. You couldn't comment on the fact whether or not there was cardiomegaly, given that the chest x-ray was taken in AP. You would say there's no evidence of any effusion, and there's nothing else of note on the chest x-ray. So treatment. How would you go on to treat this patient? As always, you should take care of the patient's ABCs. If the patient's alert and orientated, you don't need to be worried about their airway. If you would then go on to take SATs on the patient to make sure that their oxygen saturation is above 92. If it was not, you would place a nasal cannula on the patient and titrate oxygen in order to have the patient's oxygen level above 92%. In terms of circulation then, you would like to put 2 large bore IV cannula into the patient's antecubital fossa. You would ascertain a blood pressure, and you would also then want to go on to do all these other interventions. So when we're thinking of a patient's circulation, there's different ways to monitor end-organ perfusion. One of them being to monitor how well the kidneys are doing. So you want to assess urine output, and that's why you catheterize the patient. So this is part of your circulation if you consider circulation to be end-organ perfusion. So you would catheterize the patient, you would get a VBG to assess the lactate, which again is another marker of end-organ perfusion, and the patient's GCS then would be another surrogate marker for end-organ perfusion, how well they're perfusing their brain. If they're getting confused at any point, you know that this is generally a bad sign. So if the patient had any of the systemic inflammatory response syndrome markers, had 2 of the 4, so them being the white blood cells greater than 12 or less than 4, temperature less than 36 or greater than 38, respiratory rate greater than 20, or heart rate greater than 90. If it had any of those, if it had 2 of any of those 4, then you would consider the patient maybe septic. You would go on to do your interventions in a timely fashion, being cognizant of the sepsis 6 survival campaign. So you'd want to give antibiotics. You don't want to delay antibiotics. For every area delay antibiotics in septic patients is a 7% increase in mortality. You would give fluids. Generally, you would give 20 mils per kilo, and normally you would give Hartmann's or Ringer's lactate. You would place the patient nil by mouth, and you would like to do a lactate level at the start, as well as then following antibiotics and fluids to see if that had come down, and that is a good prognostic indicator if someone's lactate comes down quickly following intervention. So if the patient gets recurrent diverticulitis over, say, a several month period, they may require surgical resection of that segment of bowel that's giving rise to recurrent diverticulitis.